You can stop me at any point if you have any questions or anything like that. So knowing about the impacts of substance use on moms during pregnancy is something that all healthcare professionals will run into. And so from any field that you're in, you will likely encounter this in practice. One big thing to keep in mind is that women who use substances, and other women, may not have regular periods, and they may not know that they're pregnant for a while because they don't get regular periods. And sometimes you'll hear people in the clinical setting, say, well, how could she not know? It's very reasonable that she would not know. Substance use affects women from all races and ethnicities, and it has worldwide, global impacts. So it's important to know that someone who is struggling with substance use will not look, talk, act, speak a certain way. It impacts everyone. Whether or not a mom continues to use substances, she should still be encouraged to engage in prenatal care. And it goes both ways. If she's in substance use treatment, but doesn't yet want prenatal care, it's okay. Let's treat her substance use disorder, and she may engage in prenatal care later. Let's say she's in prenatal care, but doesn't want substance use treatment right now. That's okay. Let's continue doing prenatal care. And when she's ready for one or the other, then she can be. But what could really be important is integrating both into the same treatment setting. The most important thing that women with substance use disorder struggle with is shame and guilt. And this is a lot of the reason that women may avoid the healthcare setting. They may not engage in prenatal care or addiction treatment. And they feel guilty both for impacts on themselves and their child. And so a focus would be to talk about how this is a chronic disease. And if it were easy to just say no and stop using, I mean, we wouldn't have this epidemic of addiction. So helping a mom through those negative and tough emotions and empowering her is a key role that you'll play. So it's important to not be judgmental and instead to be encouraging and walk alongside her wherever she is in her process. So in general, women have unintended pregnancies 30 to 50% of the time. So 30 to 50% of the pregnancies are unintended in the general population. Now you add in substance use, impulsivity, high risk sexual activity, mental health comorbidities, we're up to 86% in women with opioid use disorder. So discussing options will be important. And more importantly, thinking of how to integrate reproductive health into the SUD treatment setting. So SUD, substance use disorder. So if you're thinking of how to prevent unintended pregnancies, meet them where they are and offer reproductive health treatment. So women don't need to meet criteria, like all the criteria of having a substance use disorder for there to be effects on the fetus. So any alcohol use at the exact right moment when organs are developing could have impacts on the child's organ development, even if the woman doesn't have an alcohol use disorder. And if she's not getting regular periods and doesn't know that she's pregnant. So that's also important to keep in mind. So today we'll look at some patterns and statistics for substance use in the female population, look at the effects of various substances on newborns, look at medications that can be used for substance use in pregnancy,
Just
And
turned it on. I had
think
to,
about,
we've got a patient, like we have to refer some patients sometimes from the MDU to here, so I wanted to talk to Dr. Yerke today and she just left, so I had to go do that.
Sorry.
No, that's okay. I can hear the tone at the end, like, oh, I have to do that too. I understand that tone. So discussing approaches to woman-centered treatment is also important. So the stats will come from NSDUH, so the National Survey on Drug Use and Health, and it looks at people who are 12 years old and up who are not in institutions. So this slide looks at mental illness and substance use in America among women over 18 years old. And you can see that 5.6% had a substance use disorder, 24.5% had a mental health issue, and 3.6% had both. This looks at the use of illicit substances among women, and you can see that cannabis is the most commonly used illicit substance. And this is from 2019, so could be before any type of legalization, plus it would be considered illicit if it's a national survey and done in different states. The most commonly used substances for all genders and ages will be tobacco, alcohol, and cannabis. So while we'll talk a lot about opioids, keep in mind that alcohol and tobacco are the two most impactful substances on people's health and pregnancies. So I will say that pregnant women are the best group to work with, and I am biased with that. They are the most motivated, and it's very rewarding to work with them. So when it comes to tobacco, 40% of pregnant women quit smoking when they find out they're pregnant. And it's important that they quit at any time. So encouraging them, before pregnancy, during pregnancy, after pregnancy, whenever they want to, and they're open to it, just always giving that positive message, because it will impact their pregnancy. It'll impact when the baby comes. It'll impact SIDS risk after the delivery. So that's also important. And there's a warning on all cigarette labeling on the boxes. And to the left, you can see the components that are harmful. And then there's also the combustion in the cigarette with carbon monoxide, and that causes the baby to not grow appropriately. And so the baby could be smaller than what would be normal at that age. They could also have developmental problems in the brain. Now, that's nicotine. So nicotine can cause developmental neurologic problems. That means that even if a mom were to use like a nicotine patch or nicotine gum, there's still that risk of potential developmental problems. And then we kind of just talk about risks and benefits. So yes, the nicotine patch or gum has this risk, but we know a cigarette definitely has that risk, plus more risks. And if the nicotine is, if the nicotine patch will help you not smoke cigarettes and not drink alcohol, then maybe that is a better option for you, even with that small risk of developmental problems in the child. So we give them the information and they decide what's best for them and their baby. So quitting at any time is important, especially for the risk of sudden infant death syndrome. So there's a risk of sudden infant death. Most people think it's smoking around the baby. So you'll hear, people say, well, I'm not going to smoke around the baby, or I'll smoke outside, or, I'll switch my sweatshirt when I do it, that kind of a thing. But the smoking that happens during pregnancy, even if the mom quits after the delivery, can still have an impact on sudden infant death. So I don't know why.
Hey,
But
Sarah, I can hear you.
yeah.
Can you hear me?
Yeah, I can hear you.
Yeah, but for some reason I can't hear you.
Oh, okay. Are you okay now? Can you hear me?
My device is not muted.
Your device is not.
Uh, okay, I'm just trying to see how I can connect, but yeah.
Okay. Are you okay? I think you're muted now. Are you guys okay with hearing me? Can you guys hear me okay?
Yes.
Yes.
Yep.
Yes.
Yes.
Yeah.
I think it's
Okay,
just a
fantastic.
problem for her.
Gotcha. Okay, so just keep in mind that there is a risk of sudden infant death just from the smoking part during pregnancy. So don't know why, potentially affects you know, the baby's lungs. I don't know the reason. That's something I have to look into, but that does impact the risk of SIDS. Does that part kind of make sense? Because I think that's important to think about, especially when you're with mom, throughout the pregnancy, and with delivery. Like sometimes moms might say, well, I'm going to quit later. And so it's just important to keep in mind that, the impacts during pregnancy also have an impact later on by themselves, completely independent of quitting after delivery. So that can be kind of hard to like wrap your head around, but definitely an important part because of your role with the mom throughout pregnancy. Okay, so moving on from tobacco to the other big substance would be alcohol, and alcohol goes along with sedatives, meaning like things like clonazepam, Xanax, like different benzodiazepines. So again, over 60% of
I can hear you
women,
now.
you can. Okay,
I
sounds
just
good.
switched to my phone. It looks like my computer is not working for the sound, but yeah.
You're good? Okay, sounds good. So over 60% of women actually quit drinking alcohol. Now this is all women. So this could be, a woman who goes and has one drink with friends twice a month. So just keep that in the back of your mind. It doesn't mean 60% of women with alcohol use disorder, like with an alcohol problem, quit drinking. It's all women. So not very informative. Okay, alcohol use among women. So reproductive age of 18 to 25. You can see that about half of women drink alcohol. That doesn't mean that they have an alcohol use problem. It just means half of women in the population drink alcohol. Now, when we look at alcohol use disorder, meaning they drink alcohol and they have a problem with it, you're at about less than 10%. For women age 18 to 25. You move to 26 and up, you're at around like 3.5% or a little bit lower. So just to know about the numbers when you're working with the population. High levels of alcohol are found in the amniotic fluid surrounding the baby. That's probably because the baby's liver doesn't have like the development and the mass, like it's not it doesn't have that mass to be able to process the alcohol. So if it can't process the alcohol and mom drinks alcohol and it passes, it's in the bloodstream, it passes across the placenta and it goes in the fluid around the baby. And that baby can't process or metabolize that alcohol. There's going to be a lot there present to have impacts on the baby. So how does alcohol affect pregnancies? Well, a lot of times we'll hear about fetal alcohol syndrome. And that's broken down into 3 specific effects on the face. So you'll have small eye openings. The philtrum, which is like between the nose and the upper lip, will be smooth. It won't have like that shape and that dimple that we have. And then the upper lip will be really thin. And there's ways to actually measure this. So they'll actually measure the fissure. They'll actually grade how smooth the philtrum is. And then they can score it. And then the effects of alcohol on a baby go beyond fetal alcohol syndrome. So it has impacts on things that you don't see on their face. For example, it can impact the development of their heart. They could have like holes in different parts of their heart. They could have different abnormalities in their bone development. Their kidneys may not develop all the way. Their eyes, one may deviate to the side, or an eyelid might droop. So there are different impacts on the body. And not everything is just fetal alcohol syndrome, meaning the face has certain characteristics. It impacts the brain development, and different things like this. So this just looks at like a different breakdown of how alcohol impacts the body. I will point your attention to the last one, which is ARND, alcohol-related neurodevelopmental disorder. Alcohol can impact the way the baby's brain develops, and you might not see this as a baby. You might see this when the kid is in school and having trouble with learning, and not being able to really cognitively understand things in school. And that goes beyond what someone would see on a physical exam in the nursery. An important thing to keep in mind is that poverty, low socioeconomic status, has a significant association with alcohol use disorder during pregnancy, fetal alcohol syndrome, and the whole spectrum of fetal alcohol disorders, meaning the effects on the heart, the skeleton, the brain. So something to keep in mind about factors outside of the person and, things in society that can also impact outcomes for moms. Now, if someone uses alcohol, keep in mind they may be struggling with other sedatives. So sedatives are kind of like downers in a way. So things like Xanax, alprazolam, you may hear Klonopin. Some people may use gabapentin also as a sedative. So if they use one, they may be using others. And when they stop using alcohol or when they stop using sedatives, they can get really sick. They actually can't do that at home by themselves. They have to go to the hospital and get monitored. But sometimes some of those symptoms can actually look like general pregnancy. If I have nausea, vomiting, I'm irritable, I might just be pregnant. But if I start to be like really restless, I start to like be confused, I'm hallucinating, I'm sweaty, take me to the hospital. And what do we do when they come to the hospital? We actually give them sedatives. So we usually give them Klonopin, and we do a very slow taper, or we do Valium. And we have to talk to the mom. We have to say, listen, this medicine doesn't come with no risk. But if you have withdrawal on your own at home, that's life-threatening for you and the baby. You could have a miscarriage, you could have a stillbirth. And we know that this medicine may have some risks, but we know that it's made in a pharmacy, it doesn't have fentanyl in it, and we can help you off of it slowly and monitor you. So it's risks and benefits, and a discussion with the mom. Moving along to cannabis. Cannabis oftentimes comes with alcohol and tobacco use. So it's hard to study what does cannabis really do to the baby, because we might find things, but that might actually be from the alcohol and tobacco in the picture. One thing that we know for sure is that pregnant women reduce their marijuana use. So for cannabis, when women are not pregnant, most recent data that I have from 2019 is about 15% use cannabis. That goes down to 5% when they're pregnant, which is, again, a huge reason to know that pregnant women are the most motivated group of patients that we'll ever see. Okay, so moving along to stimulants. Stimulants are things like, they could be pills like Adderall, Ritalin. They could be different drugs like cocaine or methamphetamine, MDMA. Ecstasy has a little bit of a stimulant property. They do have pregnancy complications, and that's because stimulants, they stress the heart out. And when you stress the heart out, then you may not get enough blood flow to the baby. You could have bleeding risks with the baby, and the baby can also be born smaller. So effects on the baby's development. It can affect the brain, the heart, the bladder and kidneys. But this is also debated, again, due to confounders, which means people don't often use stimulants alone. They might be using other substances, and then we struggle to know which substance really led to that effect. And we don't really give meds to treat stimulant withdrawal. A lot of it will more so be like psychological. They'll feel really depressed and isolated and down. That's usually kind of like stimulant withdrawal for the presentation. Cocaine use is pretty minimal. So you can see here, the numbers are below 2%, even 1.5. Methamphetamine use below 1%. So really not a prevalent problem in the community. Moving on to opioids. Before we talked about teratogenic effects, that means like a substance that is ingested and then has an effect on the baby, meaning the baby's eyes may not be developed correctly, the baby's heart may have a problem, the baby's brain might not be developed normally. Well, when it comes to opioids, whether we're talking about methadone, buprenorphine, heroin, Lortabs, any opioid, pain pill, heroin, fentanyl, or the medicine we treat it with, methadone, buprenorphine, Suboxone, none of them have evidence of teratogenic effects, meaning none of them have been linked with like a malformation in the baby. Really what the problem is the fact that when you use opioids, there's an intoxication, which, means that there's the opioid effect, maybe called like a high. And then there's a drop, there's a withdrawal. During that withdrawal, I feel sick and sweaty and hot and cold flushes. I don't feel good. I'm irritable. Well, during the intoxication, I could overdose. That could impact the baby. During the withdrawal, I'm stressed and my body's like fight or flight, stressed out system is on fire. I could have a miscarriage. So it's not that opioids affect the organs developing like other substances. Instead, what opioids do is it has the highs and the lows, and those highs and lows lead to the risks of opioid use in pregnancy, meaning overdose, death, low oxygen delivery, miscarriage, stillbirth, things like that. Okay. So when it comes to use of opioids, 2.3 million use hydrocodone, 1.4 million oxycodone, and 118,000 with fentanyl. And again, this was 2019. And for heroin, it's about 231,000. And for both opioid pills and heroin, about 176,000 will use both. So where do people get opioids from? The majority got it from a family or friend. So they got it from a friend, a relative, either they bought it or they took it or that person gave it to them. But the majority is family or friend. And the gray part, which is family or friend, the majority of those got it from a single doctor. So this shows the importance of training providers about safe prescribing, because the majority of opioid prescription pills that are available usually came from like one doctor. And then the blue part, which is the next biggest section, would be a prescription from one doctor, meaning they actually got it from that doctor. Now keep in mind, this is talking about pain pills that are filled at a pharmacy, right? There's a whole other realm of pain pills that are pressed. So people will buy stamps from online. They will create pain pills and make them and press them and sell them. And it's not only opioids in them. It has fentanyl. Some of them could have different substances. Some of them have animal tranquilizers like xylazine in them. So this talks specifically about prescriptions from a pharmacy, but keep in mind that it could be also pressed pills, which are very dangerous. All right, so opioid misuse among women, just some statistics that are here for you to review. And how about the medications that we treat patients with, which should be methadone, buprenorphine, and naltrexone? You can see here with time that more and more women are linked with medication treatment for opioid use disorder. So comparing men and women, while the actual number of men that die from an opioid overdose is higher, the rise, like the slope of the rise for women, is much higher. Also, women have a higher risk of suffering from opioid use disorder. Women are prescribed opioids and sedatives for longer periods of time compared to men. So providers are more likely to give a woman opioids for a longer time compared to men. Okay, so this is an article about women making changes in pregnancy, and just wanted to include this for you to know the important role of working alongside a woman and encouraging her, and knowing that women do make changes. Okay, so this article is titled "The Protective Effect of Pregnancy on Risk for Drug Abuse, Population, Co-Relative, Co-Spouse, and Within Individual Analysis." And while these slides say drug abuse, we try to avoid the word abuse and just say like substance use, drug use, but I did base it off of the paper. So not my words, theirs. Okay, so the objectives of the study. To clarify the causal interrelationships between pregnancy and drug use, to evaluate whether the impact of pregnancy on risk for drug use varies as a function of parental education, prior deviant behaviors, school achievement, age, marital status, and drug use in the cohabiting father of the child. And then look at the reduction in rates of drug use during pregnancy if those persist into the immediate postpartum period. So if a woman, doesn't use drugs, does she still not use drugs when she is postpartum? So it's a cohort study, meaning they look at a group of women and they follow them along. They looked at different registrars in Sweden. All women were born in Sweden between 1980 and 1990. They were first matched with a control, so a woman who was random and not pregnant. And then they looked at genetic factors. So they matched her with a female cousin and a full sibling. Okay. They found that drug use rates were lower during pregnancy. They found that adding parental education and school achievement strengthened the association. There was the negative association was stronger in sisters and cousins, and pregnancy drug use association, just move the pictures here, became progressively stronger the more closely related the members of the relative pair were. So overall, women use less drugs during pregnancy, and incorporating education is important during the prenatal period. And women who had a higher school achievement, like prior to the pregnancy, also had better outcomes. And this also looks at other factors, like if they had crimes, prior drug use, if their parents used drugs, and if they were married or not married. So just some different factors. So compared with the immediately preceding equivalent time period, the rates of drug use went down 78% during pregnancy. That's huge. And the protective effect of pregnancy was not affected by changing marital status, It was similar in first and second pregnancies, and it was stronger in the second half than in the first half of pregnancies. So marital status doesn't matter. If it's their first, second, or third child, doesn't matter. And women will be more likely to reduce their use in the second half of their pregnancy. We see that clinically. I don't know if you see that clinically, but definitely in the second half of pregnancy, more women are getting into treatment compared to the first half. I don't fully, I mean, this is from the paper. Sometimes we see things, so I'll also tell you my clinical experience. But postpartum period concerns. So during the first year postpartum, rates of drug use fell even lower. They then climbed gradually, so that by approximately 2 years after, the rates of drug use were similar to those observed during pregnancy. Clinically, we know that the highest risk of recurrent substance use is like 9 months. Okay, so anywhere like 6 to 9 months, 9 to 12 months, but definitely 9 months. And that's because mom feels alone, not supported. Like people are showing up, like immediately after, but afterwards she feels alone. The baby's crying all the time. She's not well supported. She's stressed. That's actually the higher risk of recurrent drug use from what we see. So how do we find out if a mom is struggling with substances? Well, we get a history, we do a physical exam, and then we look for other clues. And we ask for her permission to do urine testing, and we look online to see if she got any controlled substances. It's important to both ask the woman the questions and do a urine test together. Doing them together gives you the best chance at screening for substance use. So what types of questionnaires can we give? I'll quickly go through the ones I don't, that I know don't have great evidence, and then I'll show you one that's really good. So TACE asks about tolerance, annoyance, cutting down, having an eye opener drink. This one isn't great because if I need a drink first thing in the morning as an eye opener, I probably have really bad alcohol use. But we don't want to just catch the person that just has really bad alcohol use. Not catch, meaning like find who's positive. We want to find even the woman who may have at-risk alcohol use, and I want to talk to her about her alcohol use too. So not great. Then we have tweak, which asks tolerance, worried, eye opener, amnesia, cutting down. Also not the best. And then we have the 4 Ps plus screening tool, sometimes called 5 Ps. So the idea of this tool is if I ask you about your substance use and you feel ashamed, you may not want to tell me. So I'm going to ask about everybody around you, and I'm going to ask about your use prior to pregnancy. That'll give me enough of a hint if you could potentially have a problem with alcohol or drugs right now during your pregnancy, but maybe you're just struggling to tell me. And that's why this tool is really good. So ask about parents. Did either of your parents ever have a problem with alcohol or drugs? Then we ask about her partner. Does your partner have a problem with alcohol or drugs? Her past. Have you ever drunk beer, wine, or liquor? Pregnancy. In the month before you knew you were pregnant, how many cigarettes, how many beers, how much wine, how much liquor? So the idea is to ask about others. Now, 5 Ps plus, sorry, I didn't include that here. The 5th P will be peers. So asking about her peers, if they drink or use or anything like that. And the idea would be just taking away from her feeling ashamed if you're asking her about her substance use now. So when the baby comes, how do we test for substance use? We can test the meconium from the baby. We can check the baby's urine, look at the cord blood, get it from the mom's urine, and things like that. So how about treatment? Well, where do women get treatment? So a lot of women go to self-help groups like AA or NA. They might go to an outpatient program. They may just go to a private doctor's office. and fewer are going to more institutionalized settings like the hospital or jail, the ER, different things like that, or a 28-day rehab. It's actually more in the outpatient setting where, you know, they're going and they're coming home and living their life. So just thinking about where you'll see, like where they are and where you'll see them. We talk about potentially offering methadone or buprenorphine for treatment of opioid use disorder during pregnancy. What are the benefits? The benefits of being on the medication is that if the mom is on the medicine and feels stable, she's not going to go through the ups and downs of using. She's now on a stable medicine and feels stable all day. So the risk, if she decides not to take methadone or buprenorphine, is that she could potentially go back to using drugs. If she goes through withdrawal, that's risky for the baby. There's a risk of miscarriage. If she continues to use substances, she's at higher risk of contracting HIV and hepatitis. She may also be in more high-risk situations involving domestic violence and human trafficking, or in other high-risk sexual activity areas. Now, the benefit of not being on methadone or buprenorphine is that the baby is not exposed to that drug. We never want to have a woman go through withdrawal, opioid withdrawal. First thing is that when someone goes through withdrawal, their overdose risk gets really high after they finish going through withdrawal. There's also a high risk that they'll go back to using drugs. Another thing is that when they have continuous cycles of intoxication and withdrawal, that has a lot of negative impacts on the baby. And the baby could actually have fetal death. There could be stillbirths, miscarriage, preterm labor. So we try to avoid having a woman go through withdrawal. We try to just get her stable on medicine that she'll continue taking throughout the pregnancy. The standard of care is to treat with methadone or buprenorphine. Methadone, she would go to a federally regulated clinic and she would drink a certain amount of methadone every day in the morning. Buprenorphine, she would go see her physician anywhere from weekly to once a month, and she would have the medication at home in a lockbox and be accountable to take it on her own at home without anyone seeing her every day. So a patient who is on methadone may need more structure. She may need someone to see her every day, like a nurse to lay eyes on her and make sure she's okay. A mother on buprenorphine may be more stable and able to manage the medicine on her own at home. So we used to always give methadone to pregnant women until the mother trial happened. The mother trial looked at the outcomes on babies who were exposed to methadone when they were in the uterus compared to buprenorphine when they were in the uterus. What they found was that methadone is better for keeping a woman in treatment. So when it comes to treatment retention, if you have a mom, she's on buprenorphine, she's in and out of treatment, you know, sometimes she's taking the buprenorphine, sometimes she isn't, sometimes she comes to the doctor's visit, sometimes she doesn't, then methadone is better because methadone, they take it every day in front of the nurse. So treatment retention is better with methadone. Risk of withdrawal, they're the same. So if a mom is on methadone compared to buprenorphine, it's not like one baby will have withdrawal over the other. The difference though is, let's say both babies have withdrawal, like the baby exposed to buprenorphine and the baby exposed to methadone. The baby exposed to buprenorphine will be in the hospital for a shorter time. They'll have less severe withdrawal, and they'll require less medicine, if any, compared to a baby exposed to methadone. So knowing that babies born to mothers on buprenorphine have better outcomes compared to babies born to moms on methadone. Buprenorphine is preferred. But at the same time, whichever medicine keeps mom stable and in treatment, that's the right medicine for her. Because neonatal opioid withdrawal is extremely treatable. But a mom with uncontrolled opioid use disorder who has an overdose, that's not as easy to treat. So just keep mom stable. It doesn't matter what dose the mom is on. You could have a mom on 16 milligrams of buprenorphine or Suboxone, and the baby has no withdrawal. You could have mom on 4 to 8 milligrams of buprenorphine or Suboxone, and that baby has withdrawal. So it has everything to do with mom and the baby's genetics and nothing to do with the dose. I can't tell you how many women try to wean off buprenorphine, or they'll say, I try not to take my dose so that I'm not harming my baby. No, it's okay. This is actually good for you, and it keeps you and the baby stable. If you actually try to wean off of buprenorphine during pregnancy, that's a risk for miscarriage and stillbirth because the baby is experiencing that withdrawal. And same goes for methadone. So talking to mom that whatever dose she needs to have her opioid use disorder controlled is the dose that she needs and she should be on, and that she's doing the right thing for herself and her child. Oftentimes we have to go up on the doses during the 3rd trimester, just because there's more fluid circulating in the body, and they tend to need some higher doses. They may also need to be dosed more times throughout the day. So engaging a mom in methadone or buprenorphine treatment improves her health and her nutrition. It reduces OB complications, and it improves the health of the infant at delivery. So it does have pretty positive impacts outside of just not using opioids. If they're on methadone or buprenorphine, then we have ways to control her pain after the delivery. This is one of the huge concerns that a mom will have. The biggest concerns are, how am I harming my baby? Will my baby have withdrawal? What am I putting in my baby? And the second one will be, what if I'm in pain? What are they going to give me if I'm on methadone or buprenorphine? Well, if they're on buprenorphine, we go up on the dose and we give it more times during the day. So let's say she was on 8 or 12, we'll go up to 24 and we'll give her 8 3 times a day. And that'll control her pain, her substance use, and then Tylenol and ibuprofen on top. Let's say she's on methadone. Sometimes they'll split it up more throughout the day. Sometimes they'll go down on the methadone and then give pain medication on top of it. But there are ways to treat their opioid use disorder and their post-op or postpartum pain. One take-home message would be Tylenol and ibuprofen, when dosed and given correctly, can be more than enough to control pain. So neonatal opioid withdrawal is usually associated with genetics. So we're finding more genetics as the reason that some babies have withdrawal and others don't. And it can occur in up to 80% of babies. And that's if the baby is exposed to opioid pills, heroin, or the medications we give, like methadone and buprenorphine. It's important to let a mom know that if she's on methadone or buprenorphine, her baby can, it has a pretty significant risk of having withdrawal, but letting her know that that doesn't mean that she's harming the baby and that this is something that's very treatable. So babies' withdrawal tends to fall into 3 categories. There's autonomic instability, which can be the baby's temperature could be off. Their heart rate could be really fast. They could have irritability in their central nervous system, like they could be irritable, yawning, a little tremulous. And then they could have feeding difficulties, meaning they may not breastfeed enough or bottle feed enough. They may have vomiting. They may not be gaining weight appropriately. So no matter the withdrawal that the baby is going through, whether it's from opioids, buprenorphine, methadone, cocaine, alcohol, they tend to fall into these three categories and what you'll see in the baby. It depends on what was the time that the baby was last exposed to the drug, which drugs are used together. So a mom who is on methadone maintenance, her baby will have withdrawal much later than a mom who's on heroin, because heroin doesn't last as long as methadone. So who would we monitor for withdrawal? Well, if I know mom has a substance use disorder, then I'd monitor the baby. If the urine toxicology is positive, or any toxicology, cord blood. If mom is on methadone or buprenorphine, I would monitor for withdrawal. And then interestingly, if mom uses tobacco, you may also monitor for withdrawal, because tobacco use could really be associated with other substance use. Some people also with domestic violence, because that also can, or intimate partner violence, that can also be associated with substance use and all of that. This slide just shows the three categories we talked about. So the nervous system, the autonomics, and the feeding issues. Before, we would use these lengthy scoring tools, and women felt really judged. They were like, my baby cried a certain way, and then the nurse gave the baby a high score. When I think my baby was fine, or my baby yawned, and then they scored my baby high. So we have a new method. We can ignore that. We have a new method called Eat, Sleep, Console. And instead of looking at all these little scoring factors for the baby, all that matters is, does the baby do its normal functions? Does the baby eat, sleep, and can the baby be consoled? So it's much more mother and family centered. We won't show this video today. Okay, so eat. So again, instead of a huge scoring card, it's just these three factors now. Is the baby able to eat at least 1 ounce per feed or breastfeed well? And always encourage breastfeeding. So a lot of women actually start breastfeeding and then stop. So over 70% will start with breastfeeding, but by the time you reach like 12 weeks out, a significant portion have stopped. So encouraging breastfeeding, addressing any barriers is really important. Sleeping. Is the baby able to sleep for at least 1 hour undisturbed? And console. Can the baby be consoled within 10 minutes? And if not, can we add a second caregiver or non-medication? And then if they need medicine, then that's an option. So in a busy, like nursery or NICU, like an ICU for babies, if they don't have enough nurses or caretakers to actually soothe and console the baby, they actually have these robotic bassinets that will have like calming, like water sounds, and also rock the baby a little bit to try to soothe the baby. So this is a non-medication way to treat withdrawal. And then supportive care comes first. Give the baby to the mom, close the lights, minimize the noise, minimize the amount of people coming in and out, and just create a soothing, dark, quiet environment with mom as treatment. So the mother is the treatment. Okay, we could skip this. And then sometimes we do need medication to treat withdrawal. How long do we monitor the baby? Usually a week. By a week, if nothing has happened, pretty good. You're okay. Very unlikely that there will be withdrawal. With that said, sometimes the combination of methadone with different psychiatric medications the mom may be prescribed, it could happen after a week, but very, very low incidence. So you got to monitor at least 3 to 4 days. and then maximum a week. So what do we talk to women about during pregnancy? So things that they want to learn about. They care about how to care for their newborn. They care about how do I deal with the shame and stigma from the nursery and labor and delivery when I get there. How do I make a plan about managing my pain, especially if I have opioid use disorder and I'm more sensitive to pain, right? Like my body is more sensitive. I feel more pain than somebody else. Bringing in a support system, contraception, things like that. So Dr. Blondell's group, he's my mentor, he actually did a study and asked women what they want to learn about. And they don't want to hear how to be a good mom. That's not what they don't want to keep hearing that, or they don't want to keep having classes on that. They want to talk about shame, stigma, medication, baby's withdrawal, pain management. Those are the things they actually want to talk about. So another thing that is important for moms to learn would be family empowerment and parenting competency, in the sense of how do I navigate healthcare when my child is sick? How do I know about community resources that could be helpful for me and my family? How do I build social support and peer support, which could be really powerful for my recovery and my growing family? And so we could skip this for time's sake. For legal issues, drug use during pregnancy is not illegal and should not be. That would just punish women more and steer them away from treatment. Now, if there's positive urine tox, before, I remember when I started working, they would just call CPS right away. Makes no sense. Like, find out if the woman is on medication. And because once a mom hears CPS, not okay. I mean, that's not okay, like right after delivering a baby. Because a lot of times they'll just contact us. Yeah, we have her on the medicine. She's doing great. And then everything's closed. The only time that forcing treatment can be helpful is if it's linked with retaining or regaining custody of children. So something like Lighthouse, Madonna House, different things, or outpatient treatment, where it's not like punishment, it's just more like encouraging, and it's linked with keeping custody of her kids as a motivator, compared to just losing custody. Rather, keep the baby with the mom and give her treatment while the baby stays with her. That's powerful. How much time do you guys end at 3:30? It's 3:30.
I have it scheduled until 4.
Oh, okay. Okay.
I thought we'd have a Q&A when you were done.
Okay, sounds good. So domestic violence is a huge killer of pregnant women. Domestic violence is associated with substance use disorders. There are intergenerational cycles of violence. And domestic violence is missed a lot as a diagnosis. There is an association between substance use and domestic violence. So how often do they occur together? About half the time. About 85% of victims are female. Over 20% of perpetrators used substances right before they inflicted domestic violence on their victim. Substance use is actually more common in victims than in non-victims. And this is where you also get a lot into human trafficking, which is really major in the Buffalo area. Many victims were coerced into using, and domestic violence victims are more likely to use substances during pregnancy than non-domestic violence victims. So thinking that a woman who's pregnant, who's in a domestic violence situation, will not use drugs because she's pregnant. No, she's in a DV situation, and she's going to numb that more. She's actually going to be more likely to use than not use. Trafficking, the most human trafficking that occurs with substance use, the woman may become involved with trafficking to meet certain physical needs like shelter and food. With time, the trafficker will then use substances, meaning giving the victim substances or withholding if she is not amenable to what the trafficker wants from her. That's also implicated with DV and substance use. So alcohol use is a risk factor for domestic violence perpetration. And yeah, okay. Substance use is also associated with being a victim of domestic violence. So alcohol use in the perpetrator and definitely also substance use in the victim. So this study looked at 107 women for 1 year. In the group that did not use substances, 5% of GYN patients were abused and 7% of OB patients were abused. Now, if you look at the group that uses substances, none of the GYN patients were abused, but 15% of OB patients were abused. So that number doubled. But keep in mind, the group that was studied was significantly lower for substance use compared to non-using. So when we say intergenerational cycle, what does that mean? That means if I grow up in a home where I witnessed domestic violence in my parents, I could then become a bully at school. I could then be involved in maybe teenage rape or domestic violence in a teenage relationship. I could then have domestic violence either perpetrate or be the victim in my adult relationship. I could then create a home that has domestic violence and my children are exposed to that. Then that child could become a bully, and that bully or the person being bullied could then become involved in teenage domestic violence and rape. And then they could become the victim or perpetrator in an adult relationship. And the cycle just continues. So domestic violence does transfer across generations. Domestic violence is a misdiagnosis. Many women are diagnosed bipolar, borderline personality, anxiety, and half the time the domestic violence diagnosis is missed. So please, when you're with women and they're struggling with their mental health, ask about domestic violence. Ask them if they feel safe at home, because it is very prevalent and not diagnosed enough. All right, so moving along to postpartum care. The most important thing for a healthy child, because I know we talked a lot about the effects on the baby. The most important thing is to treat the mom. So effectively treating a parent is the most important intervention for the child exposed to substances, both prenatally and during childhood. So mom comes first, both during pregnancy and after delivery. If you take care of mom, the child will naturally be taken care of. So some take-home messages, treating the pregnant woman starts before she's pregnant. Women who use substances are an extremely motivated group, and unfortunately, they are the most stigmatized group of people who use substances, more than men and more than non-pregnant women. Treating with methadone and buprenorphine for opioid use disorder is the gold standard during pregnancy, not abstinence. Eat, sleep, console is now how we assess if a baby has withdrawal, and it's more mother-centered. And taking care of mom, both during the pregnancy and after, is going to have generational impacts to come. And that's all. Do you have any questions?
Thank you so much. There were a couple of questions in the chat that I'd like to start with, and then you can raise your hands if you have questions. So Tanya asked if secondhand smoke has a similar effect on infants as it does a pregnant person.
Yeah, that's a great question. Studies that have looked at the father and the grandparent and the mother, and the impacts of smoking on the child. The mother who smokes, that'll have the most risk because the baby is mostly with her. But there still is a risk for the grandparent and the father, even if they smoke outside and even if they change their shirts. But the mother's smoking has the biggest risk on the baby, more so than the mom or the father or the grandparent. That's a good question. As far as how to address this, I think it's important to see where she is, if she's even ready to quit. And then also for family members, just saying, okay, and did the family members get their Tdap? We want to make sure that, you know, they're vaccinated for pertussis. You know, another thing to protect the baby would be to think about how smoking affects the baby. You know, who's going to be around the baby a lot? And, you know, do you think they'd be open? Do they have a family doc that they could visit and talk about smoking cessation with? That's probably how I do it. That's a good question.
Here's another question. I'm going to read this because I'm not a medical person. It says, is there work being done in Western New York to educate specialties like neurologists and pain management clinics on the risks of multiple sedatives in ways to reduce polypharmacy?
Yeah.
That was from Joshua, and maybe Joshua could.
That's a good question. I mean,
Yeah. Oh, I'm sorry.
No, go ahead.
Yeah, I guess the question is related to the fact that, you know, we put a lot of emphasis on opioid reduction and teaching providers to reduce opioids. And I guess the question then would come up as, you know, all of these other drugs in addition to an opioid, which almost always happens because somebody from pain management or neurology will throw them on multiple ways to treat pain. Is there anything out there that's suggesting that these providers, or suggesting to these providers, that maybe enough is enough and maybe we don't need to have all of these medications on board? And how do you, like, once you've got somebody on all these medicines, how do you start to wean them off of them?
Yeah, that's a good question. I don't know the answer on how much education is happening with them. I know that our department has not specifically done training with neurology and pain management. We actually, we had the Dent farm fellow actually come and talk to us about cannabis. So I think that's a huge opportunity for us to maybe look into, and a really great suggestion. I could say that at Lighthouse, if I have a pregnant woman and she comes in and, you know what I mean, she's been prescribed like gabapentin and muscle relaxers and different things like that. Then for gabapentin, I tend to wean them off slowly. There is a withdrawal from stopping gabapentin, and some could even have a seizure risk, not always, but I tend to wean that off slowly. And then muscle relaxers and things like that, we just stop and offer alternatives like muscle rubs, TENS unit, things like that. But yeah, that's a really great question. Yeah, definitely something that I think we need to think more about.
Thank you.
Thank you.
And then Valerie asked about the screenings, the neonatal screenings for, she wanted to know if they're routine or only if an SUD is known.
Yeah, no, routine. So universal screening. So all women should be screened at their prenatal visit, and different offices and clinics can do it differently. Like some may give a certain questionnaire, and they might use different questionnaires. Like they might use audit or DAST for alcohol and drugs, which are used in like general population. Some may use the ones we talked about that are more specific for a pregnant woman, and some may not even use a questionnaire. They may just ask the question like, do you drink? Do you use alcohol? Do you use drugs? So the ones I showed you were specific to pregnant women, with the 5 Ps plus being the best one. But that doesn't have to be like a standard that's used in practice. Every practice does it differently. And it's universal.
So I have a question. You spoke about the stigma for anybody who's using substances, but particularly for pregnant women. and we have some doulas here, so I thought I would ask this question on their behalf. What can you do for someone who is in prenatal care, who is getting the stigma from her providers? What should we do? I mean, I obviously providers should be trained and know that this is something that's totally treatable during pregnancy, but how do we help advocate for patients who are in that situation?
Yeah. I'd probably start with being compassionate, like, so you just being like a safe, trustworthy person that offers empathy and compassion, just so that she feels more validated and less judged. I would also let her know that that wasn't fair, that shouldn't happen to you. But the problem is that while we try to educate healthcare providers, she can't control them. She can only control her perception reaction. I think the more compassion, empathy, and support that she gets from her support system will be helpful for her, and encouraging and empowering her to speak up for herself. You know what I mean? And I had a mom at the Lighthouse, and the Lighthouse is a 6 to 9 month program. Women don't have access to drugs there, and it's a pretty intense program. And she usually goes and sees her midwife or OB at Sisters. And then this visit, a different OB came in, and he was very like cold and judgmental. And he told her, he was like, "So you're not using? Well, when was the last time you used? And aren't you using?" And you know what I mean? Like very, very stigmatizing. And she was really, really hurt by it. And it did impact her. And I think the only thing I could offer was to be empathetic, be supportive, let her know that she is doing the best thing for herself, and that she's doing her best. So I don't think like a quick fix, but I think just being compassionate, being a cheerleader, being a support system for her, letting her know that that wasn't right and she doesn't deserve that. She deserves a lot better. And that, it's her right to say how she feels and to speak up for herself. And I mean, I wonder, do they ever like ask you to help advocate for them? Like, is that something they could ask you to maybe do, or would you encourage them to advocate for themselves? Like, how does that work for your role?
Does any doula have anything to say about that?
Well, for one, it's all into getting to know the person that you're with, if you need to step in, or if they can handle it themselves. I mean, we're there for support, so that means support in whatever way that is, right?
Yeah, that makes sense. That's great.
So we have a question from Lori and then one from Steph.
Yes, I did OB at Sisters postpartum for 24 years, and we did the NIS babies, and like during that time we were seeing antidepressant moms having a lot of the same symptoms, the babies. So, and they were saying they were doing research on that, and I didn't know if you knew of anything, if they were still working on that. Looking into antidepressants with withdrawal because the babies do have some withdrawal symptoms. The breastfed babies did much better, so we could see.
Yeah, no, you're right. Yeah, there's definitely withdrawal syndromes associated with antidepressants. And they still fall into those 3 categories. The baby not feed well, maybe have some vomiting, not gaining weight as expected, irritable, not sleeping well, things like that. So very similar in terms of the breakdown of the withdrawal. And again, mom is treatment, support, a quiet environment, and breastfeeding. So very similar, and there's definitely withdrawal associated with antidepressants. But with that,
Good.
oh yeah, oh no, I was just gonna say, but with that said, the conversation during pregnancy in terms of risks and benefits.
Right.
If the antidepressant really helps treat mom's mental health and keep her safe and feeling well, then we would support her continuation of that medication
Right.
throughout pregnancy. Yeah.
Okay. One other thing, just for the doulas and stuff, I had a patient, actually, she was the one that found it. There's an app on their phones with the maternal heartbeat. And when she got her baby settled, the NAS baby, it really increased the time of sleep for those babies. So I was telling the mothers to do that. And a lot of them had started doing that. They just put it in the, next to the crib, and it's like a maternal heartbeat. And it really soothes the NAS babies. So that's just something that the doulas can maybe teach them,
What's it called?
It's like a maternal heartbeat. It's an app on your phone.
Oh,
They
okay,
can just
that's
go
cool.
into any maternal heartbeat, and she used to just stick it on the side of the crib, and it would be her heartbeat, and it really did. The baby did sleep much better with the heartbeat going. It was kind of neat that the patient found it herself. So then I spread it to the other patients, So if they could
That's
teach
neat.
them,
I
it
like
may help
that.
some babies. Yeah.
Yeah. If you find, because I just did a quick search, maybe I'll also search this, but if you know the name, let me know, because that would be
Okay, I'll put it in the chat. I'll look through them. Yeah.
okay. Thanks. Yeah, I would definitely tell moms about that.
Thank you, Laurie. Those were great questions. Steph?
Hi, I have two questions. One, I was just wondering if if New York State had changed their, like, I don't know if it's a requirement, but I know that they do offer like the smoking cessation program, like through the state, where you can call the phone number and they do give the nicotine patches or gums for free. But I do know that they do not offer it to pregnant moms or moms that are breastfeeding. They won't offer it. And I was just wondering if they've potentially changed their stance on that or providing it, because I know their reasoning was that it's not tested on babies or like newborns or pregnant women. But my like common sense thought is, but if we know that like nicotine from a cigarette and all of the side effects of secondhand smoke are detrimental, and if like the mother's trying to stop, or like even if you have everyone in the household trying to stop, like do they offer that? I don't know if they've changed that or not.
Yeah. I didn't even know that, and so that's something I would have to find out. I actually didn't even know that. But I
Okay.
agree with you, it doesn't really make sense.
Yeah, because I know a lot of like OBs, they will offer that to their patients, and then the state's just like automatically you're disqualified from getting that if you are pregnant or breastfeeding. And then the other question that I had, and I don't know if you had mentioned it or not, I was trying to do my best to like listen, but if administering the buprenorphine has a less severe withdrawal on the baby post-delivery, are clinics now offering to kind of administer that daily versus the methadone? Like, I know you said sometimes it depends on the structure of like the mother, but do they give that daily instead, or is it just they would only do that with the methadone?
Yeah, no. So buprenorphine, like a woman would just fill it at the pharmacy and take it home. So she wouldn't have to take it daily. I know in Canada, they would go to a pharmacy and take methadone or buprenorphine daily at a pharmacy. So that option is there. But in the States, they can't we wouldn't dispense buprenorphine daily, even from a pharmacy. When it comes to offering it at a methadone clinics are a lot, they have a lot of federal regulation, and they even have problems like integrating primary care there, and things like that, because they're really only licensed to give methadone. Like I know some of my colleagues, they were doing benzodiazepine tapers out of methadone clinics because their patients were struggling with benzodiazepine use, and they were told they can't do that either. So there's like a lot of regulation, because I do hear you're saying, okay, well, if they need that daily structure, how can we put daily buprenorphine as an option? But because of federal regulations, it's hard to bring in outside services into a methadone clinic. And it's usually, it's dispensed at the pharmacy. I wouldn't have someone pick up buprenorphine daily from a pharmacy. I think that would be a lot. And there's a higher risk of them not going, missing a dose, and kind of like all the potential issues with going back to using or overdosing. So I probably wouldn't do that. And also insurance gives you a hard time if you fill more than 4 scripts in a month. So sometimes even sending like a 3-day and then a 7-day and then a 4-day, like that even gets to be problematic.
Oh, okay. Well, that makes sense. I was just wondering, so I was like, well, if we know like the benefits versus the risk, I wasn't sure how much like difference there was, but I know there's always like reasonings behind the reasonings. So thank
Yeah.
you for explaining that.
Yeah, definitely.
Thank you, Steph. Those were great questions too. You guys are so smart. Does anyone else have any questions? See what I have in the chat. Oh. Anyone else? Look and see. No other hands. Well, what a great, huge group here. We had to listen to Dr. Abdelsayed. Thank you so much. I'm going to put in the chat a link to our events page where you can see our the other opioid education presentations like Dr. Abdelsayed's. We're going to have somebody talk about harm reduction and opioid use disorder on February 9th. Cheryl Moore from Erie County Department of Health will be here. We're going to have a history of opioid use in the United States given by a professor from UB on March 1st. We're going to have, and then in April, I'm sorry, in March, on March 14th, we're going to have teens and opioid use disorder. And then really happy in April, we're actually going to have Dr. Joshua Lynch speak at the medical college on fentanyl and how that is really the face of the opioid crisis today. So that's going to be in person too. We're very excited to finally be able to get back to face. But so that's available. Yes, I can email it. I'll email it to everyone, Laurie. Thank you. I'll email that and I'll email the flyer as well. So lots of thank yous to you in the chat, Doctor.
Thank you. Thanks for having me.
Thank you. It was very good.
Thanks. Be safe driving.
Thank you. Bye.